Okay. Okay, first I'll discuss about anemia in pregnancy. So Shan, can you tell me what like few points that you'd ask your mother is anemic in pregnancy?
In the history, yes. Like
Yeah,
on presentation or in the history?
history. Let's say it comes at
So
36 weeks.
you should ask the for previous antenatal records and check the booking visit hemoglobin,
Mm-hmm.
and then see if they have detected the hemoglobin hemoglobin levels, and if what they have done, like blood picture and ferritin levels, and if it has increased after giving a double dose iron.
Mm-hmm.
Uh, that's about it, no? In anemia? What
Yeah,
else?
so when you get a patient with low hemoglobin, you ask the current hemoglobin levels, and then anemic symptoms like shortness of breath, lethargy, if she had recently, and then like you said, you can ask about the booking visit hemoglobin, and then if she was regularly followed up in the clinic, and then before that, you can also ask about causes of heavy bleeding. So like if she had previous menorrhagia, hookworm, peptic ulcer diseases, and then the diet is also you can ask in the social history. Then you can ask if she has any family history of any bleeding, hematological diseases like thalassemia, spherocytosis. And then other important things you can ask about the spacing. If she is recently, if there's like poor interval between the pregnancy, that also can predispose to anemia. Then the number of children and pre-pregnancy folate. And then, like you said, the booking visit, you can ask if she was symptomatic or was she asymptomatic, and if she took any folate before, and if she had iron deficiency before the pregnancy, if she was given worm treatment, and other important things you can ask is her blood group is important. Why do you think her blood group is important?
Because if it's low during when close to term, we have to either transfuse, or if they have symptoms, you have to transfuse blood. So it's important.
What else? Anyone?
Get to know about the Rh negative?
Yeah. If she's rhesus negative, and if you're being given before the pregnancy, if you're given positive blood, then that could also sensitize the mother. So those are few things you had to ask in the history. And then heart failure features, orthopnea, paroxysmal nocturnal dyspnea. And then other thing you didn't ask is about if she had any high intrauterine growth restriction. It's not very common with anemia, that's what Suranga said, but you can still ask. Then on examination, you can check the anemic features. If she's thin, that can also suggest she's malnourished. And then the other thing is the symphysis of fundal height. If she has IUGR, would be reduced. And then you can also ask in the gynecological history if she had fibroids, and if she's a grand multipara, those mothers are also more prone to get anemia. And then if she's a thalassaemic patient, you also have hepatosplenomegaly. And important to do a full cardiovascular system examination, because if she has heart failure features, you have to exclude that also by examination. So she will have fine crepitations, ankle edema. All mothers have mild ankle edema, but if she has like a moderate or severe ankle edema, that could mean that she has heart failure. Unlikely you get a severe heart failure mother for the exam, but yeah. So investigations depends on when you get a diagnosis of anemia. They can be asymptomatic, and the booking visit is when you usually check the anemia levels, and at 28 weeks. And the other test you would do is like the serum ferritin, total iron binding capacity, protofirin. So when you are checking the hemoglobin of a mother, first trimester it should be at least 10.5, second trimester 11, and third trimester it should be again 10.5. And then how would you manage, let's say, mother before she wants to get pregnant, what would you have? How would you advise her? Yeah. Yeah. Hello.
Anemic mother.
Yeah.
So we have to ensure that the serum ferritin levels are above normal before she can get pregnant.
What else?
Ideally, we can do a blood picture and exclude any pathology if it's there.
Yeah.
And we have to optimize the hemoglobin
Yeah.
level to more than 12 before she gets pregnant.
If she has a hemoglobin of, let's say, 9 in the booking visit, how would you proceed?
If she has less than 9 in the booking visit, then we can start on oral iron because we have time to correct it. In spite of, usually don't start in the first trimester, but in this case, we might start. And then you check the hemoglobin within a week, and if there is a rise by 1 gram per deciliter, then you keep continuing that. If not, we will have to do further investigation, and then yeah.
Yeah. How much iron would you give?
So you have to give 100 milligram of iron daily.
So yeah, how would you categorize the iron deficiency anyway into mild, moderate, and severe?
Yeah. So mild is between is from 11 to 10, and then from 10 to 9 it is moderate, less than 9 is severe.
Yeah. No. Guideline, okay, what does it say?
Guideline less than 7 is severe, 7
Yeah.
to 10 is moderate, 10 to 11 is mild.
Yeah. No. That's right. And then according to NICE also, it's a bit different. NICE, okay.
And the ferrous sulfate dose is 200 milligram, right?
Yeah, 200 milligram, 120 milligram elemental iron should be given.
Yeah.
So according to the RC OG, mild is 10 to 8, 8 to 6, but according to Sri Lankan guideline, what Ashin says 7 to 9, 9 to 10, and then 10 to 11 is mild. So yeah. And then so how much should the hemoglobin be? If a mother's hemoglobin is 7, what would you do?
Then we will have to transfuse blood ideally if
Yeah.
she is symptomatic.
Yeah, if she's yeah, if it's hemoglobin is 7 at any gestation, it's good to do a blood transfusion. Or if she's severely symptomatic, you have to do a blood transfusion. And then delivery, you can, there is no contraindication just because you're anemic, you don't have to go for C-section. You can do a normal vaginal delivery, but you have to preserve more than I think 1 pint of blood, at least 2 to 3 pints, because they are more prone to get postpartum hemorrhage. And then active third stage management. Can someone tell about active third stage management? Rivka?
So active third stage management includes 3 components. So that is the control cord traction, delayed cord clamping, and giving oxytocin or ergometrin. So oxytocin can be given 5 international units.
Yeah. And then after delivery, what would you do?
So as in,
After mother has delivered the child, would you like to do anything else?
so we have to ensure that there is no PP. If there is no PPH, or if there is PPH.
Meows chart. Okay. I monitor with the meows chart. So what are the complications you can get is in the fetal if you have anemia? Yeah, you're more likely to get intrauterine growth restriction, miscarriage. Yeah.
In the postpartum period, after you deliver the baby, after the news and everything, before like in the next day, aren't we supposed to like do another full blood count like before discharge?
Yeah, no? Yeah.
And see.
What? Yeah, no, yeah, do a full blood count after the delivery also. Full blood count, and then other thing is after delivery you can advise the mother to not having any children, have adequate spacing for the next child, because they are, if they have a child soon, they are again more prone to get iron deficiency or any type of anemia. And the complications they can have is a few complications. Is fetal complications they can get is miscarriage, preterm labor, intrauterine growth restriction, and the maternal complications is during pregnancy they can get heart failure, and then during delivery they can have postpartum hemorrhage and sepsis. They are more prone for postpartum hemorrhages because iron is needed for myoglobin production. So if there is low iron, there's less myoglobin production. So there's chance of there being reduced contractility after delivery. So therefore, you are more likely to get postpartum hemorrhage, and you are also more prone to develop sepsis when you have iron deficiency anemia because I think because you're immunosuppressed when you have iron deficiency anemia, right? Yeah. Yeah. Then other options of if the patient if is not tolerating oral iron, you can then consider giving IV iron, and both are same efficacy. But when it comes to replenishing stores, IV is better. And let's quickly pretty much a quick summary of anemia. Now I quickly go into rhesus negative. So rhesus negative, most important thing you have to ask in the history is the blood group. Okay, and then other thing is in the opening statement, you can also ask about miscarriages. Miscarriages is important because if she's a rhesus negative mother and she had a miscarriage, there could be fetal matter hemorrhage, which could have made her sensitized before. So if she had a miscarriage, you immediately should ask if she has been given rogam. But usually miscarriages after 12 weeks, only you give rogam. Only a few instances before 12 weeks, you give rogam. That is if you did a surgery. If she, mainly if you did surgical intervention, then you have to give rogam. And then you can ask about the number of pregnancies. And if in the previous pregnancy, the child's blood type, and if rogam was given, and the mode of delivery. If the mother knows, you can ask the rogam dose. And then important thing you have to ask in most mothers in the booking visit is if they have been going to the blood bank, because they are going to send to the blood bank to check the antibody levels. Because mother won't know if you ask. Some mothers won't know if they antibodies have been checked. So you can ask if they've been sent to the blood bank to check the antibody levels. And then you can ask about the other thing about the previous pregnancies. You can ask if she had any severe severe postpartum hemorrhage, and how was the labor? Was there any delay in the labor, and if she delivered the child by C-section or normal vaginal delivery? And then if she's a sensitized mother, important thing you have to ask is how often the antibody levels are checked if she is being referred to a hematologist, and if antibody levels are like elevated, if she's been referred to a fetal medicine specialist. So some others won't know this fetal medicine specialist, so you can ask if they've been transferred to Ragama or something, because Ragama is, I think, the only one of the few places which has a fetal medicine specialist, where most mothers are being referred to. And then if they had any previous IUGR or current baby, if there's an intrauterine growth restriction, and then the father's blood group, you can ask, but then that is sometimes subjective. And if the mother had any previous transfusion, hemoglobin levels, and then during this pregnancy, if she had any threatened miscarriage, and if she had any threatened PV bleeding in the third trimester, if she had, example, any placental abruption, which is managed conservatively, or any placenta previa, which lead to PV bleeding. And then if a CTG was done, if she had any previous intrauterine death, and Kleihauber test, and jaundice. Then on examination, there isn't much. You can ask about anemic features, and if there is intrauterine growth restriction, there would be a decreased symphysis height. Some others, I think, when they have, you can even check for preeclamptic. You can ask about preeclampsia features. And I don't know why. I think mothers who have been sensitized are more prone to develop this, but don't write that down. But I think it's a point to remember. And yeah. So the pathology, what happens simply in a rhesus negative pregnancies, when you have the first baby who is rhesus positive, the blood enters the mother. Then she initially produces IgM, and then IgM becomes IgG later on. IgM is the antibody that does not last long. IgG is the antibody that's long lasting. And this IgG can enter and cause hemolysis, and this can cause anemia in the fetus in the next subsequent pregnancy. And this can lead to heart failure and even eventually intrauterine death. So events which can cause this rhesus negative sensitization is like miscarriage, antepartum hemorrhage, ectopic, then placental separation, and then even abdominal trauma if you did any previous invasive procedures. Then you're more prone to have fetal maternal hemorrhage, which might need which might be a sensitizing event. And then in rhesus negative mother, important thing to do is during delivery you clamp the cord early, and you cut the cord away from the umbilicus to facilitate exchange transfusion. And you don't clamp from the maternal side. You collect, and while you do this, you collect the cord blood for full blood count, bilirubin, DT, reticulocyte count, and Coombs test. So full blood count, bilirubin, DT, reticulocyte count, and Coombs test. Then during the pregnancy, if the mother has not been sensitized, you give Rogam at 28 and 32 or 34 weeks 500 international units, or sometimes they're only given one dose of Rogam 1500 international units at 32 weeks. And after delivery also you give Rogam 1500 international units, and then you can do the Kleihauber test and give the rest of the Rogam. So each milliliter you give 125 international units of Rogam, and a vial of Rogam has 1500 international units. Before 20 weeks, the maximum amount of Rogam you can give is 250 international units, because the maximum fetal maternal hemorrhage before 20 weeks is 2 milliliters, so hence 250 into 2. If threatened miscarriage, you give 250 international units as well, and if bleeding continues, you give 6 weekly till it settles. You give Rogam continuously 6 weekly until it settles. Yeah, so let's say a mother is sensitized, then you can then no point giving Rogam. Then you check the antibody levels. If the titer is 15 or 1:32 or less, or less, then you monitor every 2 weekly. If more than 1:32, then you monitor with amniocentesis 2 weekly, or ultrasound scan and Doppler. Amniocentesis is not routinely done, so you can monitor with Doppler. So if so, you monitor with if there is any anomaly in the Doppler, then you can do this special test known as a peak cerebral flow. And if that is abnormal, some guidelines says 2.5 multiples of median, some say 1.5. I think the Sri Lankan guideline says if it's 2.5 multiples of median, then it's possibly the child has anemia. In that case, you can do chorosynthesis, and if the hemoglobin is less than 9, you can do a transfusion. That is if the PO is less than 34 weeks. If the PO is more than 34 weeks and the hemoglobin is less than 9 in the fetus, you can deliver. And yeah. And so that's about it. And when you're transfusing a mother, also if she's rhesus negative, best to give O negative blood. And yeah. Any question? Did I miss anything?
Kavi, you said a name of a test after Kleihauer, right? What is that?
I did?
I mean, some of the name. Kleihauer. After the delivery, if you don't Kleihauer, which you do, or is there anything else?
No, Kleihauber, and then yeah, only Kleihauber. No, one Q and one N.
Okay.
Is the antibody level correct? 1:32 or 15?
Yeah, the critical value is 1:32.
Yeah. And then so again, I just repeat it. So let's say the mother is sensitized, then you check the antibody levels. If the antibody levels are in the critical value that is more than 15 or 1:32, then it is suggestive that the child might be having anemia. Then you have to monitor the child by doing ultrasound scan and Doppler or amniocentesis every 2 weekly. And then if the Doppler is also showing anomalies, then you go for another test known as the peak cerebral flow, because when a child is anemic, there will be increased blood flow to the brain. Yes, we give drogam after delivery. There will be increased blood flow to the brain, so therefore there will be increased flow. And then if you are doing amniocentesis, you have to plot it in this thing known as a Lilly curve. And if that is showing, if it's below the curve, then you have to do a chordosynthesis. Or if the peak cerebral flow is more than 1.5 or 2.5 multiples of median, then to chordosynthesis, find out if the child actually has anemia. And then depending on the POA, if the POA is less than 34, you can do an intrauterine blood transfusion. If it's more than 34, you can deliver. So transfusion, you do it under ultrasound scan with a 20 gauge needle straight to the umbilical vein. And you give O negative leukodepleted blood. Okay. Then heart disease in pregnancy. What would you ask in the history? Aaron? Aaron, what would you ask in a history of a patient who has this heart disease in pregnancy?
So in the history, you need to ask about the heart diseases, what she's had, and if she's on any drugs. Then
Before that,
is it
what kind of
booking
heart
visit?
disease?
Or?
It's
Yeah, what
congenital or
kind of
acquired?
heart disease?
Not a,
Yes. If she's on any clinic follow-up, then any drugs she's on, the most recent echo reports, if available.
Mhm.
And I would check the ejection fractions in the reports. Yeah.
Anything else?
Yeah,
If
what
there's
symptoms? Yes, yeah.
yeah, symptoms.
She has shortness of breath, if she has palpitations, any.
Yeah. So you know the WHO classes, and there's 1, 2, 3, 4. So how would you like, if the patient doesn't know what class she is in, usually it's normal case, how do you suspect what class she is in with the history?
You ask if she's able to do her day-to-day activities without much effort.
No, that's an IA
or she's
classification.
able to,
I'm asking about the WHO classification.
I'm not sure.
The WHO, there is class 1 heart diseases, class 2, class 3, class 4. So class 1 heart diseases, usually you can ask from the patient whether she was referred to a cardiologist. And in the class 1, they only, in the first trimester, they are sent to the cardiologist. And after that, usually there is no follow-up. In class 2, they are followed up every trimester. And then in class 3 and class 4, they will be followed up at least weekly or at least twice or once every 2 weeks. So yeah, what other things you can ask is initial booking visit hemoglobin. That is important. And what she was admitted for. If she was admitted for confinement, or if she was admitted for cardiology referral. And then other thing is, if before she got pregnant, if she had any pre-pregnancy counseling. So pre-pregnancy counseling asks what drugs she's on, if there was any end organ damage screening, and if a disease was optimized prior to being pregnant. And then how many times she's been referred, the blood pressure in the booking visit, pulse rate, if she remember, is unlikely. If she had any history of infections, because these can also precipitate heart failure. How many times she's been admitted, if there is any IUGR, which is possible with heart failure, and if there's heart disease in previous pregnancy, what contraception is on, and if she is on any drugs like warfarin, and if the warfarin was changed in the first trimester. And then ask about the birth weight of the previous children. That is so important if there is suspected previous pregnancy, if there is suspected intrauterine growth restriction. And on examination, you check the patient's build, if she's dyspneic, pallor, cyanosis, oral hygiene, JVP, ankle edema, infective endocarditis features, pulse rate, murmurs, blood pressure, and if there were any creps on auscultation. And investigations in heart disease patient, you can do like ECG, echo, chest X-ray if she comes in the booking visit. And then you should know briefly about the changes that occur to the heart in pregnancy. So the pulse rate increases, then the stroke volume increases, cardiac output increases by 40 to 50%. You'll also get a systolic murmur in the pulmonary area, and there might be an ST heart sound. Diastolic blood pressure falls in the first two trimesters, and there's increased blood flow to all the organs. And sometimes the apex beat might go from the fifth intercostal pace to the fourth intercostal pace, which is normal in pregnancy. The management, if she was counseled before she got pregnant, or if she wasn't, and then important is if she was managed by a multidisciplinary team, and then in the management is very important to treat anemia infection early and look for heart failure features, and if there is any severe lesion, like to limit the family size. And then in the third trimester, if she has done routine growth scans and if there is any IUGR. And then what else is during the prenatal period, that's about it. And then the labor. Labor is important. So WHO class 1 and 2, you can go for a normal vaginal delivery. Class 3 and 4, it is contraindicated and best to do a C-section. Class 4 pregnancy is contraindicated, so if it's less than 12 weeks period gestation, you can terminate the pregnancy after 12 weeks. The risk of being pregnant and termination is the same. So class 1 diseases are example, mild pulmonary stenosis, repaired VSD, and mild patent ductus arteriosus. Class 2 is unrepaired VSD or ASD or repaired tetralogy of Fallot, or if she has like any arrhythmias. Class 3 is like cardiomyopathy, left ventricular failure, or if she has any cyanotic heart diseases. And class 4 is severe pulmonary hypertension, severe heart failure with ejection fraction less than 30% and Eisenmengers. So when it comes to the delivery, the mode of delivery again depends on the symptoms and WHO class as well as the NIHA class. So first stage of monitoring, first stage of labor, you monitor as usual. Once the cervix is favorable, you can send to the labor room. You is best to inform the seniors as well as the cardiologist. Important thing is adequate analgesia. Best to give epidural. And if you are doing ARM, it's said you can give prophylactic antibiotics. And make sure the second stage is not prolonged. And best to do monitor the mother's vitals in a multipara monitor. And then after in the second stage, to avoid prolonged second stage, you can either do instrument or vacuum delivery. Third stage can manage actively, but you should avoid giving ergometrin as this can worsen heart failure. And then postpartum, again, you can do a full blood count, check the hemoglobin, manage with the Meows chart, and do a cardiac assessment. So complications is you can develop is you can get pulmonary hypertension, pulmonary edema, heart failure, arrhythmias, miscarriages, fetal heart defects due to the drugs, or if she has a congenital heart disease, the fetus also can get it. And if she's having a valvular heart disease, she might be on warfarin. So you tell her to stop taking warfarin from, or refer to a cardiologist who will tell her to stop taking warfarin from 6 weeks to 12 weeks, and he'll start on enoxaparin during that period. Then after the 12 weeks, you again restart warfarin, and then when you close to labor at about 36 weeks, she again be changed to enoxaparin. And when she's close to labor, like which is going to deliver within a day or 36 hours, you can then change from enoxaparin to heparin. And then 6 hours before labor, you stop heparin and then restart it 6 hours after, and then start the warfarin in 5 days. And then quick brief about peripartum cardiomyopathy. Peripartum cardiomyopathy is like a rare condition which you get heart failure in the last month of pregnancy due to pregnancy to the months postpartum, and there is actually no cause, and the left systolic, there will be severe left systolic dysfunction. In these cases, you have to give adequate bed rest and contraception advice, as well as if there is a pregnancy, to terminate it. And important is the fluid management, and you can also place for AC inhibitors. Okay. Yeah. Then past section. Is my speed okay? I'm just going fast because speed is okay now. Hey.
Yes.
Yeah. Okay, Ashan, can you tell me what you'd ask if it's a past section in the history? Ashan?
So first I would
I
like to
have
know
a
how many past section you said, right?
Yeah.
Like what pregnancy this is, she has, how many past sections she has had. And
Okay.
then I'd like to go to the antenatal records of, if it's just one, I'd like to go through the antenatal records thoroughly to see what was the indication for the past section. Or if I can get that information from the mother, fine. If there are any deficits, I would like to go through the past antenatal records. So I want to know what was the indication, what was the type of incision that was made, if there were any complications of that infection, like of that incision afterwards, like scar and so infection and complications. I want to know the birthing, the spacing, the interval between this pregnancy and the last one. What else?
You can also about if she had any vaginal deliveries also before the past section.
Yes, sorry. And if she has had any, successful vaginal deliveries in the past before that.
And in the scans, if there was any previa or abruption in the anomaly scan or in any scan. And if there's in the current recent scan, if there's an abnormal presentation, that is also possible if you had a past section. And then on examination, what we look for?
On examination,
Nothing much. But
so on examination, I want to assess the fetal, depending on the gestation, I want to assess the fetal presentation. I want to assess for any scar tenderness, uterine scar tenderness.
yeah, that's the important one. And the presentation is about it.
Yeah.
And management is past sections, like a normal pregnancy, close follow-up. The dates you should be confirmed, and then the important thing is the placenta localization, if there is any morbid deteriorating placenta. And then you can do ultrasound scan to check if the placenta location is in the scar or if there is any placenta previa. Did someone ask a question? No. And then
Sorry, what did you ask?
no, I'm not asking. I'm just telling this management.
Sorry.
And multidisciplinary team is important. If you're having like a morbidly adherent placenta, you have to inform the blood bank, the gynecologist, the midwife, and even the neonatologist. And when you're inducing, you should be careful if you're using oxytocin. And if you're delivering a child, you should deliver it in a tertiary care center. Then there are like contraindications for VBAC. If you have a T uterine scar, That is a contraindication. Another thing in the history, you can ask if it did upper or lower segment cesarean section. And then if she has any previous uterine rupture, you can't do a VBAC. And then if there's abnormal presentation, again, can't. Previous surgeries for incontinence is also contraindication, and previous perineal tears. Then if she's going into labor, have IV access, keep fasting, then monitor with a planogram, adequate pain relief, send blood for grouping and DT, inform seniors, good hydration, and be vigilant of uterine rupture. Second stage as usual, and third stage active management. If the placenta does not come, exclude morbidly adherent placenta. And then signs of uterine rupture is like there will be suprapubic tenderness, abdominal pain, and then there might be vaginal bleeding, and fetal tachycardia is also another important sign. And there will be reduced contractions if there is impending rupture. And another important thing is try not to use prostaglandins when inducing labor. And if the mother is having a breech presentation, you should avoid doing external sexual version if she has a previous uterine scar. And yeah, another important thing is that if the delivery interval is like less than 1 year, it's better to do a C-section other than normal vaginal delivery. And yeah, anything else in C-section? Last section? Natural. Yeah. Then I'm going to restart the meeting. Fetal fetal tachycardia. So the cardinal signs of imminent rupture are worsening CTG. There can be variable or late decelerations. Hematuria is also possible. Secondary arrest and small amounts of vaginal bleeding. And then signs of uterine rupture is it's fetal bradycardia, not tachycardia. And then there will be sudden loss of contractions, maternal hypotension, heavy vaginal bleeding. Okay, I'll restart.